Yep, we can see it just fine.
Looks good.
Good. Now let's get started. So, that's the first slide, always needs a little bit of encouragement. So good to see you. I'm from over there. It's sort of, if you draw a horizontal line from Rotterdam to the German border, we're sort of on next to the border, but the Netherlands is pretty small, so you're there in a hop. These are my disclosures. Everything I earn sort of goes back to the hospital. Sometimes we get to buy new stuff for that, which is cool. And let's just get started with a little bit of history here, because neuralgic amyotrophy is a syndrome that's been known since, I think, the 1860s, and I'm sure it existed before that, but this is a large case series from 1948. It was described by the gentleman Parsonage and Turner, and some people call it Parsonage Turner syndrome because of that, but they actually called it neuralgic amyotrophy, so I sort of stuck to that name. And there's an old story and there's a new story in there. So the old story is that this is a disorder with like 40 synonyms, ranging from brachial plexus neuropathy to Parsonage Turner to serratus anterior palsy. Well, you can think of a few more. I don't care what we call it, as long as we know what we're talking about. It's a very acute, painful brachial plexopathy. That's the old story. It's supposed to be rare. You need an EMG to make a diagnosis. There's no proven treatment, but you don't need to worry because everyone recovers. Well, starting from this point, I think we need to say goodbye to the old folks here. We've been running a Plexus clinic in 2009 that was specifically designed to find out and then treat the persistent problems that people with neuralgic amyotrophy have, even after the first year and a half following their diagnosis. And we've been interested in this disorder since 1995. It's sort of a hobby that got out of hand, as is ultrasound, by the way. So we found out a couple of things along the way. And I wanted to start out with the epidemiology, because it's supposed to be rare, but I think, well, it's like a needle in a haystack, but if it is, it's this needle. And I think basically every one of you should be able to find this one. NA is a really weird disorder, at least in the Netherlands. We had this football player who always used to say, you know something when you recognize it, and you recognize it when you see it. And NA is like looking at there's some sort of animal standing right in front of you in a dry country. It has 4 legs, a big body, and then a head. And you think it's a horse, but it has these white and black stripes on it. And if you've actually never seen a zebra, then you don't know what it is, right? But if you know that zebras exist, you don't need to think about it twice. So that's NA. Once you know that it's there, it's quite common, actually. And we tried to get some sort of feel for how common it actually was in the Netherlands when we did this study in 2012. So for a year, we followed a group of general practitioners who took care of about 14,000 people in our population. And we asked them to chart all their diagnosis of shoulder problems, new onset, which were about 500 patients that year. And then if they saw anything peculiar with the shoulder blades, so they needed to undress the patient, turn them around, look at the back, at the shoulder blades, have them make a big abduction and flexion movement. And if they saw anything weird, just put it on a small smartphone film and just send it to us. And they found 14 people who we eventually diagnosed with definite neuralgic amyotrophy. So 14 in 14,000 is 1 in 1,000 a year. That is not rare. That's even in the Netherlands, which is a small country, it's 17,000 people each year. So, and I think most of my colleagues who eventually learned about this tell me that they tend to see it all the time. But if you don't know it exists, it will always be a rare disorder for you. So if I translate these numbers to like the UK or the United States, that would be 300,000 plus people. And I'm not sure if that's the experience that you have right now. Funnily enough, Guillain-Barré syndrome, which is a very well-known disorder for neurologists at least, is much rarer. It's about 1 in 100,000 a year, maybe 2 or 3, depending on where you are in the world, but it's really not that common. So this is a slide with the guy there and my head on the chopping block, or based on the looks of it, I think it just came off. But so I just wanted to make this statement that why don't we really? Because if you fill in neuralgic amyotrophy in PubMed, you get about 500 hits. And if you fill in Guillain-Barré syndrome, it's about 10,000 hits for disorders that have a reverse incidence. And that's weird. And that's probably because in Guillain-Barré syndrome, it can be life-threatening. So can NA sometimes, but not that often. And there's a treatment for it called IVIG, and that makes a lot of people interested in doing something about it. So that's sort of we are left behind here and we need to catch up. So let's look at something new, like the phenotypes. And these patients, they always remind me of this poor T-Rex that has beautiful teeth and strong legs, but sort of lacks in the upper extremity here. It's a clinical diagnosis for me. And I know that Jeff asked me to talk about EDX in neuralgic amyotrophy. But basically, if you don't recognize it clinically, it's going to be pretty hard to do a good EMG exam for these people. So it starts with a clinical suspicion and a clinical confirmation. And to make life worse, there's a couple of different phenotypes that the patient can present with. So the classic one, which is about, in our experience, 75% of the patients, has a very typical phenotype with acute pain and then scapular winging, or at least dyskinesia, and exorotation weakness and long thumb flexor weakness, or anterior interosseous palsy. But there's others too. So about 1 in 10 will have phrenic neuropathy with orthopnea, and about 1 in 10 will have involvement of their legs, so the lumbosacral plexus. So there's a couple of different varieties here. But this is classic. And this is also a photograph from the 1880s, I think, on a beautiful historical archive website, which shows a guy with neuralgic amyotrophy. I'm sure if we could have made pictures in the Stone Age, you would have seen the same in some people. But it's acute. And usually these patients tell you that they woke up early in the morning, late at night, with, you know, a nasty pain in their shoulder or back, radiating into the arm sometimes. And within a couple of hours, that pain became unbearable, like 8, 9, 10 out of 10 on the numerical rating scale. So if you undress them, turn them around and look at the scapulas when they move, you can see that there's something not right with serratus anterior. And then you can look at shoulder exorotation and the long thumb flexor, and you'll find weakness. And if you have this pattern, there is no differential diagnosis, basically. So then you have the diagnosis. And this is what patients tell me that it feels like in the acute phase. It's like being tortured with hot rods being poked into your shoulder, into your body. It's horrendous. They just crawl on the floor, begging you to do something about it. The arm is constantly held very close to their body, and it's so annoying and overwhelming that they can't do anything else for a couple of weeks. And usually when they tell you a few months afterwards, they're quite calm about it. So sometimes we really have to dig into the history and ask them to put a number to the severity of the pain. So force them to choose a numerical rating scale score. Well, this lady is a fitness instructor. So she's really healthy, really fit. And she has neuralgic amyotrophy. And now this is the first group question. Just anyone can shout out if you want to. But which side is the affected side here? Anyone want to venture a guess?
Maybe the right.
Yeah. Could you tell me why you think it's the right side?
The medial border of the scapula looks a little bit more elevated than on the left side. It just looks a little bit more protruding outwards. And then the top border also looks like it's coming more laterally.
Yeah, great. So you were already there. It's the right. But I think the point of this is it's a small video, and it's just to show you that even if you can see it, if you look closely, by just looking at this still image, it becomes much more apparent if you have people move. So if she tries to elevate her arms, you can see that there is almost no scapular movement there, no serratus function. And the more she does it, the more obvious it will become, because it's very fatigable. That's every nerve lesion, but you can use that in your physical exam, so to keep repeating it until you see it clearly. So we asked them to make this movement, and you also see her tilting her body and trying to sort of bend over to get her arm to go to a higher position. And she's using her trapezius and her levator scapulae to lift the shoulder, so it's much closer to her body as well. She's also using her pectorals and rhomboids a lot more. You can sort of imagine that all these muscles that are compensating will become pretty painful if this is what they need to do every day. So if you want to look for this diagnosis, I think that's probably this slide. there's a 5-minute, you don't have an excuse not to do it, exam strategy. Undress your patient. I know you often use like shirts that they keep on, but in this case, you really want to see the shoulder blades. So bra is fine, but a shirt should probably come off. And then stand behind the patient and have them make this movement, capture it on a video, and then look for anything that's asymmetric in the scapular movement or position on the chest wall. And then if you don't want to do the whole 50 muscles strength testing protocol, just do shoulder axial rotation, long thumb flexor, pronator strength. And if the combination is abnormal, you usually have the diagnosis. So that just brings us to the first case. Can the EMG be normal? Neuralgic amyotrophy. So we saw this lady in our clinic, 43 years old, and she had acute onset pain, unbearable, NRS score 9 for 3 weeks, about a year and a half ago. At first, she was completely unable to abduct and antiflex her shoulder, but she experienced some improvement in the first 6 months. And then things have just been getting worse. So the shoulder pain became worse. She had to stop doing her work. She couldn't do sports anymore. And then she had physical therapy because she's very committed to improving her health. But actually that just worsens her pain during and especially after the treatment. And her current mood is miserable. So this is the lady. And she's also going to show you that abduction antiflexion movement. She's getting instructions now, and then she will try and start to move. And this is what happens, and it hurts. So just look at the video and tell me afterwards what is weak. So her rotator cuff is also hurting. It's impinged. Yep. And she asked if she'd done it right, and she did. So would any of you venture a guess on the weakness, or what do you see here? What happens? How would you describe this in the chart?
Something like,
Brianna. Okay.
yeah, something like right scapular winging consistent with serratus weakness. I don't know, something's going on with her deltoid too. She can't get above kind of that first 90 degrees, but if she's having pain, I'm not sure if that's weakness or pain, but I would say she's having pain with it too.
Mm-hmm. Definitely. Yeah, this is very awkward for her to do. It's because we asked her to put it on a video, and she's even on one of our websites. But yeah, so you say it's serratus weakness. And I can totally see why you say that. Let me just try and rewind the video and start it once more. So at first you see the very high position of the shoulder blade here, right? So this is active by trapezius and levator. And here there is no serratus activity when she tries to elevate her arm. Basically, the serratus should sort of turn the shoulder blade and keep it under the humeral head. It doesn't happen. You see a good volume here of the rhomboids, no serratus function, and all of a sudden the whole shoulder blade is retracted medially, which is rhomboid and trapezius probably. And then she tries to release like this. So, and here you actually see good movement of the shoulder blade. So here too, wow, this was serratus just kicking in there. So there is serratus, but it's somehow not working properly. And so now we're going to make a small sidestep to the actual topic of this story. It's like the electrodiagnosis, because her EMG was completely normal. And that might be a little surprising if you see how she moves. So for you guys who aren't familiar with this structure yet, this is sort of a schematic of the brachial plexus, obviously. And it's a really, really big structure in your body. So it's 5 roots, 3 trunks, 3 cords, about 10 by 5 by 3 centimeters, the main thing in the interscalene region. It must be over 100,000 axons in there, 11 big end branches, and about 50 muscles attached. As a neurophysiologist, I'm always a little, put off by referrals saying brachial plexopathy, ? Because that's actually not really a question. It's like, is there something wrong with the body, right? So you can do EDX all day and not find it if you haven't examined all these structures. And in our country, we limit an EMG exam nerve conduction plus needle EMG to about 90 minutes. So that's the time frame where it needs to happen. And then you really need to be a little more precise in the referral. I'm not sure if you share the same experience, but it's quite common here to have people referred like that. It took me a couple of years with this big thing on my desktop as a wallpaper. So now I'm able to draw it if I could draw. And I know where everything is, but it's very complex. And so we try to make it a little more schematic like this, and try to separate these different parts of the brachial plexus in the very proximal regions, like the roots and the trunks. And then you have this clavicle overlying it. And if you're caudal to it, you're in the cords or terminal branches. And by, assessing all these different end branches, you can sort of form an idea of where in this whole structure the pathology must be. So you try to combine measurements to find out where things are. And it all starts with anatomy. You really need to be aware of the anatomy. You don't need to know it by heart. You can just look it up in a book or on an app, whatever. But it needs to be taken into account. And then you combine nerve conduction studies and needle EMG to find or exclude nerve involvement. And the basic rule is that you surround anything abnormal with other structures. And if they are normal, you know where the lesion sort of ends or is not. And then a very simple rule, but sometimes forgotten, is that you can only say things about the structures you actually measured. So we had people referred saying upper brachial plexopathy, meaning the superior trunk. But if you never measured the inferior trunk and it's also weak, you have missed half the diagnosis. And it also in our country, that's not uncommon. So this would be the first strategy for general plexopathy questions. You're going to use the nerve conduction studies and then the sensory part to find out which of these cords and trunks are involved. And they're pretty logically and anatomically organized, because if you start in the lateral side of your forearm, going from here to the thumb, to the middle finger, pinky, and then the medial side, you actually have like the structure of plexus brachialis, here superior trunk, and then you go to middle trunk, lower trunk, and most inferior part. So you can use these nerve conduction studies to scan the whole structure. So if you turn the arm around 90 degrees, they sort of overlap. And this is actually the evaluation protocol we use for traumatic plexus injury, where you just want to know which elements are affected. If you have a different strategy, I'd be happy to hear it, but this is how we screen. The only thing is that for neuralgic amyotrophy, unfortunately, this doesn't work because it's not a brachial plexopathy, first and foremost. We're going to talk about that when we discuss imaging a little bit further on. But also we've done thousands of sensory nerve conduction studies in these patients, and they almost never are abnormal. So it just doesn't help to separate a postganglionic brachial plexopathy, let's call it that for lack of a better word yet. But it doesn't help these sensory nerve conduction studies to separate that postganglionic involvement from preganglionic radiculopathy, for example. Basically saying, don't use nerve conduction studies to rule out neuralgic amyotrophy or rule in radiculopathy. Now here's more of the anatomy and the schematic. So the superior trunk can be sampled by these conduction studies. Lateral antebrachial cutaneous is probably the most cranial structure that you can measure. It's part of musculocutaneous. And then medial and radial to the thumb and the axillary nerve. And that will sample sort of this region. Now, middle trunk is basically C7 root that will split into two parts pretty quickly when it leaves the foramen. And so you're going to measure the radial nerve to the base of the first digit, or the median nerve to the middle finger, or C7 elements, like this. And then inferior trunk is C8T1. So there's a lot more going to the hand and distal nerve conductions that you can do there. And the most caudal one is actually, I think the routine one is the medial antebrachial cutaneous nerve that you can measure. There is also a medial brachial cutaneous nerve for the upper arm, as we call it, but that's not a routine nerve conduction study. Can be done, don't do it often. Usually we use these guys. One of the pitfalls here, for those of you who haven't done much of this nerve conduction study work yet, the median nerve, the APB muscle is T1 innervated, so a very caudal element in the brachial plexus. The median nerve, the sensory innervation, is C5, C6. So it's big separation in the thumb between the sensory and the motor part. And that's good to be aware of, otherwise you get confused. So this would be the C8 to the ulnar and T1 medial antebrachial cutaneous. So you end up again with something like this. You can sample all these elements by using the equivalent of the hand and the recording sites. Now, for this group particularly, because I'm not going to discuss all the techniques to do needle EMG in the upper extremity with you, but safe needling of serratus anterior has, I think you can do it two ways. And first one would be to do it blind. And this is just a quick, just interested question from my side. Do you use ultrasound to guide your needle EMG? Anyone?
No one that I've worked with has done that.
Okay, well, you don't?
Maybe Botox or an inject tape, but not often just a regular EMG.
Okay. So we have an ultrasound machine in our EMG room, and we actually use it pretty often, especially when we get people referred for like nerve transfer surgery, and you really want to know something about a very particular muscle or even part of the muscle. Just a suggestion here, but for serratus, it's pretty handy, because if you want to do it blind, you usually put the patient on their side and then feel for the edge here of latissimus dorsi and retract it with your fingers, and then put your fingers in between the ribs where the lines are here, sort of, and then meaning that anything that's between your fingers is now on a rib, and that's serratus anterior. So if you just stay between your fingers, you will be on the rib, not going into the lung with the needle, which is nice, because the lung is not a structure of interest here. And then what we usually do is that we stick the needle in the direction that this black arrow is pointing at. So we actually point it posteriorly and just follow the rib. The other thing you could do here, and I'm not going to, this is a whole video of how you could scan serratus, but it's just to show you that this, I hope you see the video moving, but these are the ribs here. This is the lung, the pleura, and these are obviously the intercostals here. And then these big chunks of muscle here on the ribs, that's serratus. And you can see if you enter the needle here, you're going to be in the lung pretty quickly, like 3 centimeters, and you're there. But if you use the rib as a backstop, it's a pretty safe procedure. So what we would do is something like this. Here you see, again, this is a video, but just a still image. This is the rib. This is the pleura again. So that would be 1 centimeter to, well, like 2.5 centimeters. There's the lung. And now serratus is quite white. So this is a denervated muscle. That's also the reason why we're needling it. And this is the next slip of serratus anterior, also very denervated. And then this is the subcutaneous layer, and here the skin. And the needle is going to be this. This is a needle artifact coming in. So if you stick the needle in and you follow it, you track it with ultrasound, you can see that the tip there, here, is in serratus, not going anywhere near the lung. And this is a safe way of positioning. It's a nice in-plane view you can do here. So you have the whole needle tipped to, well, not hilt, but big chunk of it. And you're certain that you're not anywhere you don't want to go. So this is usually what we do. And then we ask the patient to contract, which means that they sort of extend their arm forward against someone who can help here, a technician or maybe a resident. So this was going back to the lady with the weird shoulder and the Chinese markings on her, tattooed on her back. She had bilateral upper limb sensory nerve conduction studies, and she actually had a low snap amplitude of the lateral cutaneous nerve of the forearm on the affected side. And then we had right motor musculocutaneous nerve conduction studies, completely normal CMAP, normal distal motor latency, normal velocity. Median nerve also normal. And the needle EMG of the serratus anterior showed normal motor units, but the recruitment was very poor. But then this is something you already knew when you saw her move, because there isn't a lot of recruitment going on in serratus. It's hard for her to recruit this muscle. So does it match and explain the clinical picture, this EMG? And what would you do or advise next? And then, so I'm just going to give it back to you guys, and any thoughts on these two things would be welcome.
I guess, did you needle anywhere else, like the supraspinatus or infraspinatus, or expand your EMG kind of scope?
Yes, so she also had, I think, a needle stick in the infraspinatus, which probably showed some neurogenic motor units, like 10 to 15 milliseconds, a little larger amplitude, etc. No denervation. Does that help you?
I'm not sure.
So what would you do just by this, given this information? Would you do more? Would you do something different? Would you refer her back?
If you were saying that EMG can be normal in NA, then I think given her history and where she's at now, it does match what we were seeing on exam, but I don't know where that leaves you for next steps.
Okay, well, let's just continue then, and I think we'll get there. So just hopping back to the EDX, the nerve conduction studies, the routine motor nerve conduction studies are usually not that informative because there are not a lot of proximal nerves that you can measure routinely. For example, long thoracic is difficult. And re-innervated muscles, after a while, may have normal CMAP amplitudes. That's what I mean by normal CMAP here. Because you can do the whole CMAP amplitude with just 50% of your axon pool, so to speak. And these sensory nerve conduction studies, unfortunately, are not sensitive either in the specific case of neuralgic amyotrophy. They are good for traumatic brachial plexopathies, but not here. So this was the study where we did the, a lot of residents had to do neuralgic amyotrophy nerve conduction studies, and the outcome was always pretty disappointing. So the needle EMG obviously can show you muscles that suffered axonal loss and have collateral or proximal reinnervation, but there might only be 2 muscles affected in the whole upper extremity, which has about 50 of them. So you can needle 48 muscles and not finding the abnormal ones if you miss the relevant ones here. And so a priori, your best chance of finding something abnormal would be infraspinatus, serratus anterior in the acute phase, and then flexor pollicis longus and pronator quadratus. So anything belonging to the interosseous anterior nerve. But if you want to know which muscles you need to needle, then you have to be able to perform a good clinical exam to find the ones that are weak. And then you could sort of reverse the line of thought, saying if you can find the muscles that are weak, you already know the pattern of involvement and how good or not good these muscles are. And most people, you can, even if they are in pain, you can still examine them pretty well, unless, they are very, it's so much that they can't even be touched. But so if you can do a detailed clinical exam, I think that's the most valuable part, actually, of being the doctor doing the EDX. So this is, again, my head on the chopping block. I think, do you need an EMG for neuralgic amyotrophy? Well, basically, if you have a good history, which is fitting with that typical pattern, and the clinical exam has the same distribution pattern and matches the diagnosis, why would you even? Because, it doesn't add much to what you already know. And for us in the Netherlands, the situation is a little different when it comes to EDX, because here neurologists are the only people doing it. And usually those of us who are in general practice only do it like a couple hours a week to break the regular, fatiguing strain of patients on their outpatient clinic. But they usually have like a set of 6 to 8 routine muscles like biceps, FCR, the first dorsal interosseous, but they're not used to sticking needles in serratus. So usually there's a sample error when we get EMGs from those practices. And if you want to make or exclude a diagnosis, it's not that helpful either, because this lady has very abnormal movement, but the EMG is almost okay, except for poor recruitment. So obviously, if there's an insurance company or an employer asking for proof, we might do it, but then we do a very focused exam after we established the pattern of involvement clinically. And if your previous colleagues who saw the patient couldn't pinpoint the lesion or the diagnosis, yeah, sure. If you know how to do that, you're helping the patient. So coming back to this head on the chopping block, that I still think it's a clinical diagnosis first and foremost. And this will also help you start treatment in time, because you can treat them in the acute phase, but you don't need to wait. You shouldn't wait for an EMG after 2 weeks. So again, what you've just seen, this lady, is something called scapular dyskinesia. It's an altered movement pattern. It's a central cerebral adaptation. That's very helpful at first, because if there is no serratus anterior function at first, because the nerve is damaged, you need to sort of lift your arm with a different strategy, a motor strategy. And the strange thing is that your brain immediately starts using a different motor strategy or software program when there is a lesion. So if I cut my nerves right now, I will move differently. But your brain never checks if the hardware is back and up and running again. So you just keep on moving in that weird, strange, altered pattern. And that's what makes this lady move so bad. So we've seen her. And this is just a small trick, and I hope I can get the point across just by these still images, that you could tell weakness apart from dyskinesia by using this trick. So the automated movement in this illustration is on the left. Like reaching forward with your arm is something you do dozens of times a day. And it has an automated motor program somewhere in your cortex that if you want to reach for something, you don't even know what you're doing. Your hand goes forward and you have it. The movement on the right, this is an image I could find from the COVID period, but most people never reach with their elbow. So that's usually for people, if you ask them to, it's a new movement. And then the brain sort of has to go through a catalog of muscles going like, which one is going to be able to go in that direction with the elbow? And the only one you can find really is serratus anterior. So the weird thing is, if you ask these patients to do this, they will be weak on doing the thing in the left, reaching forward. You can push the shoulder and the arm back away from their trunk. So there's instability in the serratus. But if they perform the movement on the right, you can't push them back, because then the brain will activate serratus and it will be strong. And that is a neat trick to separate cerebral adaptation from actual hardware damage to the nerve. And here's a small video showing you what I mean. This is our physical therapist and movement scientist. That's the big guy here on the right. This is a patient. You already see he has abnormal scapular position. First thing my colleague is going to test is that automated movement, so reaching forward, and then he's going to put counter pressure on his hand, and you can see the instability, right? The scapula is sort of unstable, and he can't keep it on the same position on his chest wall. So then the other movement, reaching forward with your elbow, and here he's strong. I mean, it's not maybe 100%, but it's much better than the automated movement. And this is just a very simple trick that you can do in your practice to separate the two. And if it's like this, you won't find any abnormality on your EMG because the muscle is there. It's just not being activated, but that's a central thing. So another case here. And then we're going to sort of hop over to the people that don't recover. This is a 55-year-old male with a history of knee injury, and he works in a production plant, so heavy manual labor. And he had this acute onset pain, NRS8, again, shoulder to forearm, 10 days, about half a year ago, and then a dropped hand and fingers ever since. Clinical exam shows mild scapular dyskinesia, and then mild weakness of the flexor pollicis longus and pronator quadratus. But then he has a paralysis of the wrist and finger extensors, and that's really impairing his function. So EDX, sensory nerve conduction studies, all normal, bilaterally, motor nerve, well, no CMAP from the EDC and for the extensor indices, and then complete denervation of the extensor muscles and a normal brachioradialis. Well, so what do you know when you know this? This is complete pin denervation, basically. 5 months out. Okay, what would you guys do or advise if you saw this patient in your clinic? And here we have a multiple choice option, so just pick one. Anyone venture a guess?
I'll
not
say
a-
let's go conservative and pick B.
You'll pick B. What would you expect from extensor strengthening exercises?
I guess the hope is that he could recruit some of the muscle and eventually sort of strengthen it as time goes on.
Okay. Yeah, I can understand the line of thought, and I think a lot of colleagues think the same, but maybe it's a little bit of background info is that you can't train a muscle if you aren't able to make 70% of your maximum strength. So in this case, he's not even strong enough to lift his own fingers. So there's nothing there to train with yet. So probably that's just going to go and exert him or strain him and cause injury. So we would not advise that. We would advise normal movement, just keeping the muscle active by trying to keep it active in a functional sense in your daily activities. But in this case, we would do something else. Because this guy, 5 months out, still complete denervation, no improvement in the pin, needs a different type of workup in this phase. And for this, we're going to go to imaging. And whether you use MR neurography, so a very specialized MRI technique where you have dedicated coils and protocols to see nerves, or you use ultrasound of the nerves, which has an even higher resolution, and but it needs experience. Both do, by the way. You need to look at this radial nerve and the pin. Here you see two examples of not this guy, but just any person. Let me see, find a laser pointer here. So here is the brachial plexus, some of the elements, and the slight abnormality here is that it's slightly hyper intense in this T2 weighted sequence and a little thicker, or the diameter is a little increased. It's quite subtle, but the overall lateral resolution of MRI is not that good because you get a big overview, but not a lot of detail in the small parts, right? So, and for those of you who aren't used to doing ultrasound, this is the humerus, this is triceps. So we're at the lateral half of the arm. And here is the radial nerve, which is pretty big. Usually it's about the size of this single fascicle here. So these might be abnormalities that you could find in neuralgic amyotrophy. This is a bit of a busy slide with a text, but I think even in the acute phase, 70–80% of these patients will have some imaging abnormality if you scan the affected nerves. Some nerves you can't get to, right? So phrenic in the thoracic cavity you can't get to, or long thoracic is difficult. But the others, you can find abnormalities, and usually they are not in the plexus, but they're in the proximal nerves, like the proximal long thoracic, suprascapular, median and radial nerve, usually distal arm region, so effectively 10–15 centimeters proximal from the elbow. And so these are apparent hours from onset. It's the first thing that you can see on the inside, being proof that something's going on in these people. So if we get like young children here, first couple of days, EMG is useful and very difficult to perform without anesthesia. But we screen them with ultrasound. And if we find these abnormalities, we make the diagnosis. Some of these people will go on to develop intraneural damage, a Sunderland grade 4 lesion, which also affects the connective tissue elements in the nerve. And if you have a big chunk of connective tissue or even scar in the nerve, then it's difficult for axons to grow back. And that's what's happening in this guy in the case example. He has this intraneural scarring that prevents axonal outgrowth and reinnervation. So in him, it's just another example. This is the long thoracic on an affected side in the median middle scalene muscle, put on the laser pointer here. So this is the nerve, and this is the corresponding image on the normal side. It's a tiny nerve here in a fascia, and here is a big enlargement. And this is one of the weirdest videos I know. This is fascicular rotation. So just for your orientation, we are at the medial side of the arm here. There is the brachial artery. Here is median nerve. This will be biceps and brachialis or coracobrachialis underneath. We start quite proximal. And you just watch these fascicles here as we go out towards the elbow. They start tumbling over each other. So the top one is large, and here it makes a rotation, crawls on top, and then rotates. 360-degree turn around the other fascicles. And then when we approach the elbow region, you see them crawling over the brachial artery, and then rotate back. And now they're sort of in a normal position, but the nerve is still way too large here in between two halves of pronator. This is one of the weirdest phenomenon we know, I think, in nerve ultrasound. And I think the first time someone showed it at a conference, there was lots of cries of disbelief from the audience, but it actually happens. And I think the best explanation I have, but maybe Jeff has a better one by now, is that this is some sort of volvulus of the nerve. You know, these intestinal rotations where the intestine gets stuck behind inflamed lymph nodes. Well, in this case, your nerves, they have connective tissue sheets that run in an oblique line. And if they become swollen by the inflammation, and you have a nerve that's in a segment of your body that rotates, it might be that they kink these elements. And then you get a nerve that's sort of stuck behind itself internally. And we think that's what happens. It doesn't always need treatment. Sometimes they just revert back to normal by themselves. But in this guy, 5 months out, no recovery, you should look for these things. And if they're still there, they need surgery. They need neurolysis. Just one more time, just because it's fun. Here, that's the fascicle. And it just rotates 360 degrees here. And then again, it's going to go rotate back if we're a little more distal. There we go. And here it starts rotating back. Okay. So this would be a very typical finding in neuralgic amyotrophy. They're called constrictions or hourglass constrictions. I think you can see why. And here is that segment where the nerve is sort of twisted on itself. And this is a very corresponding intraoperative image that shows exactly the same. You can imagine that it's difficult for axons to grow over this twisted segment. So if you have this and there's no recovery, they need to start the workup for surgical neurolysis and even maybe grafting or excision and grafting and repair. If you have a good radiologist, you can do it on MRI. So this is from Daryl Snake, who's in upstate New York. He's a radiologist with lots of beautiful MR machines. And here you see the torsion site, which is a bullseye sign on the MR. This is the zoomed in version of it. Here's the radial nerve from this guy that we just talked about. This is enlarged radial nerve, also with these fascicles that rotate a little, but they are mainly too large, are encased in fibrosis and scarring. I'm going to show you the longitudinal image of his radial nerve. Here, this part here is the nerve going there, and you see the mouse tail-like constriction in this segment. So that's what the problem still is. Like that. So there's been a couple of papers on ultrasound in neuralgic amyotrophy, just showing you that it's there in the acute phase. You can find abnormalities if you know how to scan for them. And there's even a nice paper that Jeff has co-authored too here about what approach you could take to your nerve ultrasound. So make good use of it. Here's another example of MRI, one of these hourglass constrictions, intraoperative corresponding image. So if it doesn't recover, and this is a group from Germany and Austria and some other countries, German-speaking countries in Europe, then just consider surgery and start doing a workup. And what they do is do an external neurolysis, and then the nerve is able to expand again and sometimes derotate. So I think you see the derotated. Here is the constricted segment before neurolysis, and on the other half here is the expanded segment, which allows for a little bit of recovery. Okay, so we have a little time left. Let's talk about treatment for a second. Case number 3, and this is not hypothetical either. Several of my colleagues have already encountered this. You are at work early morning and your partner calls you, and they woke up with a very severe pain in the left shoulder and arm, and it's out of the blue, and your partner is healthy and fit and it's no wimp. So on the phone, they sound desperate. You're a doctor, please help me. What should I do? I shouldn't curse, so I won't. But what would you do? And then this is a multiple choice question, but I'm be happy to hear your thoughts, or if you need more info, please ask.
Let's go with B.
B, yes. And what do you have any plans for B yet?
I mean to see him and do a full history and physical.
Okay. Good thought. Yeah, we would even not get them in if that took too much time, but just to do a good history on the phone maybe. And if it's your partner, I think you'll be able to do that. And then just treat them. I would almost say, for God's sakes, please consider treating them. Because if you can stop this inflammatory process now, it might revert back to normal within a few days. I can't underpin this with any formal evidence, because if we wanted to, we would have to take the nerves out in the acute phase, put them under the microscope, cut them up and see what's going on. But that wouldn't make the prognosis any better either, so we can't. But we know that these inflammatory lesions on imaging are present within hours. And we also know from the experience that we have with treating people after different amounts of time, is that if you do this within the first days or couple of days, you have a really big chance of seeing the pain melt away like snow in the sun, as we say here, within a couple of hours. And that the paresis that's there will revert back to normal within like 3, 4, 5 days. And probably, but then again, don't put a knife to my throat because I can't prove it to you yet. This disorder is autoimmune. The etiology is autoimmune, and the initial process is probably some sort of nodopathy, paranodopathy, like axonal block at onset, that if you don't revert it back to normal, will go on to be axonal loss. And somewhere in the first week, you can see them transiting from block to loss. So please, if you can, or if it's someone dear to you, or it's a kid, don't wait. There is almost no contraindication for steroids. You can do them orally. You don't need to get them in for an IV. It's a dose that we use 1 milligram per kilogram, and that sort of topped it off at 60 milligrams per day. But the average BMI in our population is 25. So if your average BMI is higher, you might consider a higher dose. And then we taper them within the next week. And if you do this on day one, about 90% plus of the people will respond positively. If you wait for a week, that will be 75% maybe. And if you wait for 2 weeks, it's only 50. And if you wait any longer, the chance of it responding to steroids is almost 0. So, and a real responder will respond, right? So the pain will melt away. It's not that they say like, oh, I think I'm a little bit better, but you don't see it from the outside, you see it. If it doesn't work, or you have someone with a recurrence, which is actually pretty common for neuralgic amyotrophy to have a recurrence a couple of years on, then you could also consider IVIG. I think it's very effective, but in our country, it's too expensive to sort of mess around with. So we are not at liberty to start this out of the blue, and we have to pretend that they have GBS if we actually want to prescribe it. But if it's a kid who has a recurrence with still 70, 80 years ahead of them, we certainly consider this. And this might be new, and there is no randomized controlled trial, but just as a very short anecdote about the need for RCTs. So we had this colleague call and say like, okay, I have a patient just 4 days out. I think it's neuralgic amyotrophy. Do you have any evidence? And we say, no, sorry, but we tried to do an RCT, but we couldn't get people in on time. So it failed after 3 years, but we do treat them, and our advice would be just treat them. And he said, no, if there's no evidence, I'm not going to do it. And then this colleague, this actually happened, called us back a couple months later and said, my wife has NA. What's the dose? And you bet, because if you see someone having this, it's awful. And it's like we have this acute stroke service that if anyone even thinks they have aphasia or like a drooping corner of the mouth, they come in and they are worked up for intravenous thrombolysis and maybe intraarterial to save the residual symptoms in the big chunk of the population. But these people, everyone that I've seen has residual dysfunction in some part of their life, and many of them have to change work or can't do their work anymore. It's a very debilitating disorder. So I wouldn't wait. And if it's you, just start. And so the prognosis was, well, that we see that many people do not recover and have persisting pain. It's always related to that scapular dyskinesia. So you need to find a treatment for that. We've checked them with psychological questionnaires, etc. It's not a chronic pain or psychological dysfunction. And many of them lose their jobs or their sports or anything that's important to them. So this is actually from a patient from the US who came to us and said, yep, I've been told it's neuralgic amyotrophy and I need to learn how to live with it. But my doctor forgot to tell me how. So, and that's, I think you're the audience that I need to say this to, because it's a PM&R question. Basically, it's not a hardware problem. It's two things. They have loss of endurance because of the way collateral reinnervation works in your body. So you do the same work with fewer axons and they fatigue. And they have this altered movement and posture that costs a lot more energy to do things, and it doesn't go away by itself. So if you want to focus on anything in treatment, focus on these two elements. So this is just a couple of quick slides of images to show you that we looked into this with fMRI, showing that there's actually an area of the brain that changes if you have this disorder. It's not unexpected, but it's nice to have a picture of it. And then so the standard shoulder physical therapy that we do here, which would be training with weights and repetitions, that's not helpful. It's like top sports, right? You have technique, you have strength, you have endurance. And if your technique is not good, strength and endurance training will only get you damage to your structures. So to finish it off, let me just pose one more question to you. This is a guy who came to us 8 years after losing serratus anterior function. He already had a pectoralis major split transfer to the serratus, try and make it stronger. And he's in constant pain, NRS 9. And so we proposed physical therapy for this. And we were sort of laughed at, go like, yeah, 8 years out, even surgery, how on earth is that going to be helpful? And so after hearing this talk, who of you would also send him to physical therapy? Or would anyone say you're completely mad over there in the Netherlands? This needs different treatment. We should screw the scapula to the chest wall, for example.
If he was one that had the motor control problem, like if you showed me the elbow pressure trick, I would say you could still try with some sort of therapy to rework those patterns. But if not, then I don't know that that's an option.
I'm not showing you that test, but if you did it, he had more strength than he's showing right here. And don't want to keep you waiting, but this is the guy 3 months later. He also had some suntan. He looks a little better overall. But this is just physical therapy. And this is effective motor control retraining of scapular coordination. So if you have a therapist who knows how to do that with the patient, and it's difficult, right? Because it's a very automated movement. You don't have much of your voluntary control over these scapular movements, but you can activate serratus anterior. And just as like learning steps for in gymnastics exercise, right? You have to start in small steps and then in the end put them all together and automate it in your daily life. But it can be done. And so basically, this is the story about the top sports. And you need good energy dosing. Strength usually is what it is, but you don't need to focus on strength. If you want to rehabilitate these people, you need to focus on technique. And so this is our bathroom tile. People are going to ask us, can I do sports, doc? Yes, you can. You can do anything as long as it doesn't hurt you for longer than you did it. So if they want to do any physical therapy or sports and do it for 30 minutes and then recover completely, fine. But if they still have pain 2 hours later from a 10-minute exercise, it's way out of balance. And this is very simple advice that's very helpful, we find, in most PNS patients. And I think the final chopping block slide here, if you're a physical therapist and you don't know how to train technique or scapular coordination, don't treat these patients, because you will do them harm rather than good. Final slide, I think. This is new in the US. There is a brachial neuritis center, as they've called it, at UCSF. Anne Poncelet is the person leading this clinic. It's supported by the donation from a wealthy patient who wanted to set this up in the USA as well. So if you have any patients or you want to just talk to a colleague who does more of this rehabilitation, talk to Anne, and I think she'd be happy to discuss with you. So this is the final slide, and I'd like to thank you for your attention. And if there are any questions, I'd be happy to discuss.